Welcome to The Explainer. Today we're diving deep into the science behind the prescription pad, the elegant, quantitative dance between pharmacokinetics and pharmacodynamics that ultimately decides if a drug actually works.
Let's kick things off with a clinical puzzle. On one hand, you have a single pill that clears up an infection. On the other, a patient needs a staggering amount of an IV drug every day for 10 days straight. The total drug exposure is worlds apart. So how can both of these be the right answer? Well, to figure that out, we have to look past the drug's name and into the science of how it behaves in the body.
So here's our game plan. We'll start with the two core sciences at play here. We'll follow the drug's journey with pharmacokinetics, then look at its mission with pharmacodynamics. We'll see how they partner up, and then we'll put your knowledge to the test before looking ahead.
All right, let's get into it. The solution to that puzzle we just mentioned isn't about one single concept. It's a tale of two sciences, a fundamental duo that forms the bedrock of all rational drug therapy today.
The easiest way to think about it is like this. Pharmacokinetics, or PK, is all about what the body does to the drug. Think of it as the journey. Pharmacodynamics, or PD, is the flip side. It's what the drug does to the body, or in our case, to the bug. That's the mission. So let's trace that journey first. Every drug we administer has to navigate the incredibly complex environment of the human body. And its success or failure really hinges on how well we can predict that path. Formally, pharmacokinetics is the study of that movement. And of course, you know the classic acronym, ADME. Absorption, distribution, metabolism, and excretion. But for us, it's not just about listing these steps. The real work is in building mathematical models to describe each one. The rates, the volumes, the clearance, all of it. These 4 steps decide everything. First, absorption, how much actually gets into the bloodstream. Then, distribution, does it actually travel to where the infection is? Next, metabolism, is the body breaking it down and how? And finally, excretion, how do we get rid of it? You know, why did the antibiotic fail its final exam? Because it couldn't pass the blood-brain barrier.
And this table right here shows you exactly how those PK principles dictate what we do in the clinic. Look at penicillin for meningitis. It's awful at getting into the brain. So to get enough drug to the infection site, we have to use these massive IV doses to create a strong enough concentration gradient. Now, on the complete opposite end of the spectrum, you have azithromycin. It has a huge volume of distribution. It loves to hang out in tissues, and its half-life is over 60 hours. And that's why a single dose can keep working for days.
Okay, so PK got the drug to the right place. Mission accomplished? Not yet. Now the drug actually has to do something. This is where pharmacodynamics comes in. It's all about the relationship between the drug's concentration and its effect on the pathogen. So for us, in the world of antimicrobials, this means we're focused on the rate and extent of bacterial killing. We want to be able to model that relationship, often with something like a sigmoid Emax curve, to see exactly how the killing effect changes as the drug concentration goes up or down. And a central parameter in all of this is the MIC, or minimum inhibitory concentration. It's basically the lowest drug concentration that stops bacteria from growing in a lab dish. You can think of it as the bug's kryptonite level. You have to stay above it to be effective. But if you push the dose too high, trying to overcome a really high MIC, well, you might just give the patient some superpowers they never asked for, like nephrotoxicity. And this, of course, brings us to the elephant in the room, resistance. As bacteria evolve, their MICs for our drugs creep up. This surveillance data for E. coli is a perfect example. You see pretty high rates of resistance to common antibiotics. This MIC creep is a huge problem because it means a dose that used to work just fine might not be able to hit its target anymore. So it should be pretty clear by now that neither PK nor PD can give us the full picture alone. The real clinical magic happens when you bring them together. The goal is to design a dosing regimen where the PK, the drug's journey, achieves the desired PD target at the site of infection. And this isn't just theory, it's happening in clinical guidelines right now. Take this quote from the Swab Carbapenem Sparing Guideline. It basically says that for our toughest, most resistant infections, we are now officially using PK/PD principles to guide treatment, sometimes even to use old drugs in new, smarter ways. So the ultimate goal of all this work is to hit a specific PK/PD index. For some drugs, like beta-lactams, the key is time-dependent killing. We want to maximize the amount of time the drug concentration is above the MIC. We call that time over MIC. For other drugs, like aminoglycosides, it's concentration-dependent. We want to maximize the peak concentration, or Cmax, over the MIC, or the total exposure over 24 hours, the AUC over MIC.
Okay, you've been listening very patiently. Let's see what stuck. Time for a quick quiz. Don't worry, it's open note. And the main note is just everything we've been talking about. No pressure, but your hypothetical patient's probability of target attainment is on the line.
First question. Let's imagine a classic clinical dilemma. You have a patient with a nasty ESBL-producing E. coli. The lab says it's sensitive to both meropenem and piptazo. So, why would you ever pick the non-carbapenem?
The simple answer is antimicrobial stewardship. We want to spare our big guns, the carbapenems. But the decision is only possible because of PK/PD. We can choose piptazo if we're confident we can achieve its PK/PD target. And that usually means aiming for a time above MIC of at least 50%, which might require an extended infusion dose to make sure we hit the mark.
Okay, question 2.
Let's circle all the way back to the beginning. That patient with meningitis getting those huge doses of IV penicillin. What's the key PK factor that makes that necessary?
It is all about distribution, specifically how poorly penicillin gets across the blood-brain barrier. The concentration of penicillin in the cerebral spinal fluid is only about 2% of what's in the plasma. So, to get a therapeutic concentration inside the brain to fight the infection, you have to create an absolutely massive concentration outside of it.
Last question. Let's think about therapeutic drug monitoring. A patient is on gentamicin, and we're constantly checking their blood levels and kidney function. What's driving that? Is it a PK concern or a PD concern?
Well, that was a bit of a trick question. The answer is it's both, and they are completely intertwined. We check a peak level to ensure we're hitting our PD target for killing bacteria, that Cmax over MIC ratio. But we also check a trough level, which is a PK measurement, to make sure the body is clearing the drug effectively and we're avoiding the PD effect of kidney damage. It's a perfect PK/PD partnership. Speaking of which, what's a pirate's favorite PK/PD index? The RUC.
So after all that, what's the big takeaway? In our current era of ever-increasing antimicrobial resistance, mastering these PK/PD principles isn't just an academic exercise anymore. It's becoming absolutely essential for good patient care.
And this really leads to a fascinating thought about the future. Are we heading toward a day when we no longer prescribe a drug based on the name of an infection, but instead based on the pathogen's specific genetic weak spots and the patient's own unique metabolic profile? I think the answer is yes. But using advanced tools like population PK modeling and Bayesian forecasting, we aren't just optimizing a dose. We are fundamentally changing medicine to be more precise, more personal, and to preserve the life-saving antibiotics we have left.